Everybody, thanks for joining us today. We'd like to thank the Seattle Science Foundation for having us today for this interesting case series looking at geriatric spinal trauma. I'm Arjun Sebastian, one of the orthopedic spine surgeons here at the Mayo Clinic in Rochester, Minnesota. I'm joined today by one of my senior partners, Dr. Ahmed Nasser, and two of our wonderful spine fellows, Dr. James Bernatz and Dr. Brian Go. We're going to kind of lead the session today. Jim, you want to take it away?
Yes, you bet. Thanks, Dr. Sebastian. Good evening, everyone. My name is Jim Bernatz, one of the spine surgery fellows at the Mayo Clinic. I'll be kicking things off with a little introduction here, and then I'll send it over to Brian, my co-fellow, who will wrap up the introduction. Then we've got 4 cases to present and hear thoughts on this evening. So first, really, why is this an issue? Why are we talking about geriatric spinal trauma tonight? Well, it's really a numbers game. In the United States, the number of people over the age of 65 has increased tenfold in the last century. And this has been dubbed the silver tsunami, as shown in the graphic on the right. It's predicted that by the year 2050, over 20% of the US population will be over the age of 65. Now, the prevalence of, for example, cervical fractures has been shown to be 2 to 5% in this population. So with such a high number of people over the age of 65, the number of fractures is expected to be incredibly large, and even larger are the thoracolumbar fractures, with 1 in 5 adults over the age of 65 experiencing a thoracolumbar fracture at some point in their life. And more than 50% of these are attributed to low energy mechanisms. So these aren't car crashes and high energy trauma we're worried about. These are the ground level falls in the elderly that we're seeing so commonly. So why do these geriatric fractures happen? Well, it's really a constellation of things. As we've discussed in this forum and others, osteoporosis is a huge problem in this population, and the weaker bones are more subject to fracture. Sarcopenia also contributes, as people are less able to respond to their environment and to catch themselves from falling. Their medical comorbidities add up, their cognitive decline increases, and thus they're more likely to have falls, as is their vision and proprioception also decrease, leading to these risks. The most common things that we see in the geriatric population, and some of these we'll touch on this evening, are central cord syndrome, ankylosing spondylitis and dish fractures, thoracolumbar compression fractures, the low energy C1 ring fractures and Dens fractures, as well as the senile burst fracture. Now, spinal cord injury specifically is some of the sequelae of these geriatric fractures. And previously, spinal cord injury was pretty much an injury of young people. In the 1970s, it was reported that the average age was 29, whereas the average age of spinal cord injury today is over 40. By 2032, it's predicted that nearly half of traumatic spinal cord injuries will be in those over the age of 60. And we know that the mortality rate in elderly patients with traumatic spinal cord injury is incredibly high. Looking at some of these registry databases about elderly spine trauma, we can see that the mortality rate in geriatric spinal cord injury is about 20% at 3 months. In this study from the Netherlands, it showed that in 160 patients, the mortality in hospital with a geriatric spinal cord injury was almost 20%. And unfortunately, this is a point where end-of-life decisions have to be made. Much of these injuries don't actually cause the patients to succumb to the injuries immediately, but they end up having these very challenging end-of-life decisions when they are diagnosed with a spinal cord injury. And that makes our jobs as clinicians very difficult. So this is something that's becoming increasingly common and something we're dealing with more and more every day. Brian?
Great. Thanks, Jim. Let me see if I can share my screen real quick. Perfect. All right. So as Jim just mentioned, I'm Brian. I'm one of the other Mayo Clinic spine fellows. So I'm just going to go through. Jim gave us a good overview on geriatric spine trauma, its kind of prevalence. And so I'm just going to go through a little bit on our treatment approach and how we kind of deal with these patients. So first and foremost, the most important aspect of this is really counseling the patient, their family as well, to make sure that they're aware of the serious of these injuries that you just mentioned, sort of the potential for future morbidity and mortality. Analogous to kind of a hip fracture, there's an associated mortality with any sort of spine trauma, particularly in our geriatric population. It's obviously important, as Jim mentioned, to establish appropriate treatment goals with both the patient and family, and kind of really understand the gravity of the situation and what are the real goals of treatment and where the expectations would be. As with all geriatric trauma, one of the important things is to manage risk factors, one of them being osteoporosis. And so screening with DEXA scans, vitamin D, calcium, and really any elderly patient who's going to get admitted to the ED or seen through the ED is generally going to have a CT scan. And so it's an opportunity for us to look at their CT Hounsfield units on all these patients and kind of assess what their osteoporotic status is. And we always generally will follow up with bone health sort of pharmacologic treatment, particularly in the setting of osteoporosis and anyone in a surgical patient. So we strongly recommend bone anabolics in our surgical patients post-op. And analogous to the bone is the muscle that Jim just mentioned. So we're also looking at sarcopenia management. There's been some studies looking at vitamin D supplementation and how that can affect sarcopenia. And so obviously supplementing when necessary. Looking at the patient's nutritional status and making sure that they're on a high protein diet, checking their prealbumin and albumin just to optimize as much as we can. And then lastly, looking at physical therapy and frailty sort of rehabilitation programs in the setting of sarcopenia to really help with their frailty. And when we decide to go down to the surgery route, obviously perioperative planning is really important. So all of our patients are going to have obviously medical optimization by our internal medicine colleagues and geriatricians, which are critically important to making sure that these patients have the best chance of a good outcome. We discussed obviously intraoperative fluid management with anesthesia, especially in the setting of patients with ankylosing spondylitis or DISH. They can be a very large EBL that can certainly be important to talk to anesthesia about those things. And preparing, the postoperative ICU possible admission. These patients are generally very frail. They have a very low reserve. And so a large surgery that may need to happen may push them to the ICU for monitoring. And as far as surgical planning, as I just mentioned with the osteoporosis, we generally just assume that all patients have osteoporosis, particularly in the geriatric sort of population. This would be considered most likely a fragility fracture. And so that by definition, they would be osteoporotic. And so there's a high risk for implant pullout and subsidence for that. So it's important to be judicious with cement and consider any postoperative augmentation that we'll mention later on in some of our cases as well. And so a lot of the risk as far as geriatric trauma is kind of baked into the cake, but obviously we want to optimize as much as possible. The most frequent chronic complication is really pressure ulcer formation. So ensuring that patients are up and mobilizing and that the nurses, even though the patients may have some pain, but they're able to mobilize appropriately, and ensuring that there are things such as like pulmonary complications due to their decreased pulmonary reserve, they're optimized by sitting up and mobilizing as much as possible. And additionally, in the elderly population, there's always a risk of an altered mental status or a risk of delirium post-anesthesia. So just ensuring that you have a multimodal pain regimen that can minimize that risk of opioids or deliriogenic medications. Of course, if the patient is too sick, you want to avoid surgery as much as possible. Consult your palliative care, pursue non-operative management in highly debilitated patients. So in conclusion, the elderly spine trauma obviously has a high mortality of 20% or greater, regardless of what type of fracture it may be. Components of frailties, including osteoporosis and sarcopenia, are modifiable risk factors that can be hopefully optimized with simple interventions. And of course, there's still areas of controversy regarding their management. As we mentioned, the elderly spine trauma is increasing in terms of the silver tsunami that Jim had mentioned earlier. And we really need to establish best high-value practice guidelines moving forward. All right, so if there are any questions, we can take them now. Otherwise, we can go into some cases.
I had a question.
Yeah, go ahead.
Jens. So this was really great. I must hand you guys, both of you did a really superb job. For me, one of the most vexing questions is their underlying mental capacities. Secondly, nutritional status. You mentioned that we can't order in these patients like every lab test. Many nutritional labs take like 3 to 5 days to come back, at least with us. So number one question, do you use a mini mental status test to assess for dementia? or mental capacities evaluation. Number two, is there a nutritional parameter that you actually use that you found helpful, below which you will basically maybe forego surgery just due to super high risk of infection, like albumin below 3.5, something like that? Thanks.
Oh, sorry. Stuck it. Go ahead.
I can maybe chime in, at least, for my practice here, I think the albumin is really helpful. And certainly I think a lot of the literature, especially with regards to spinal oncology, has shown, it to be sort of an independent predictor for poor outcomes in the cancer population. So you sort of imagine that one is also a very good, surrogate for the same thing in the elderly population who have undergone spinal trauma. I don't personally, administer any kind of, mental status or mental health exam. But I'm curious, Dr. Nasser, do you do anything along those lines, or have anybody else weigh in?
In residency, we did a mini mental as well as a mini cog to assess before for consent. So there were a number of different things that sort of our geriatricians really kind of pushed as far as consent. So a mini cog can be a good sort of preliminary screening tool for mental capacity.
Yeah, we've had a few patients where the lack of assessment of dementia prior to intervention has been essentially fatal, and we've had patients, especially our patients in their the octogenarians and more elderly patients, where dementia has really led to failure to thrive and essentially going to hospice after a spine fracture that's operatively treated. So I do think that we're probably doing a disservice to patients by not looking at that more carefully. And so I think Dr. Chapman's got a very good point here, and we should probably be doing a better assessment of that. I honestly just try to figure out if they're alert and oriented to, times 3. If they can't really tell me where they are, who they are, what time and date it is, then I probably get at least alert enough where if they're not accompanied by family, I start getting concerned. And then I don't personally do it, but I think, again, something like what Dr. Go has mentioned is probably the next step, is some kind of mini mental status evaluation to look at, again, are we missing, some early dementia or some kind of, a way of assessing their capacity to make decisions. I think what we do here at Mayo is possibly even get our palliative care team involved early now in some of these patients before making the assessment to just jump to surgery. So,
you guys have geriatricians to help out taking care of these patients and getting involved in the social parts of it? I would think you'd have that advantage over most of us.
I mean, we don't have like a formal geriatrician necessarily, but our hospital internal medicine team here mostly is the ones who help co-manage pretty much all of our geriatric trauma patients, including the ortho trauma hip fracture population, as well as our spine trauma patients. So that is a nice thing because they can help with preoperative optimization, management of their comorbidities postoperatively, and they also help facilitate discharge for a lot of these patients as well, dialysis if they need it. So we are very spoiled and very lucky to have that service, and it's an automatic consult when geriatric trauma shows up to the ED if that hospital internal medicine's consulted.
All right, you want to get some cases going?
All right, we'll do.
Yep.
One of the, I guess in the chat, I'm not sure it's available to everyone, but one person had a question of why not start treatment for osteoporosis and sarcopenia prior to spontaneous or non-spontaneous trauma accidents. Certainly an important thing. And, for us as spine surgeons, patients may not show up to spine clinic until, they've got something or more serious in an ED or something along those lines. But obviously it's a high prevalence of looking at osteoporosis, but we certainly don't do a good job of really screening for that. And we should probably talk to our internal medicine colleagues and geriatricians if we, want to tackle that problem head on. Sure.
Unfortunately, the osteopenia or osteoporosis is really an overlooked problem, as you say. It used to be years ago, everybody had a bone density scanner on every corner, and we were picking more people up, and then it sort of went out of vogue as a lot of them just stopped doing it. And I think it's really important. We've learned from our arthroplasty that even young people can have osteopenia, so we don't pay enough attention to it. It's part of preventive medicine, which in the US we're really good at treating end stage disease and trauma, but we're not really good at preventive medicine. So it's something that should be higher up on the list of the things we're aware of and treat today.
If I may add to that, this is near and dear to my heart. This is something that we can solve systemically. I think if our radiologists could help us by doing more opportunistic CT Hounsfield units, like what Brian was mentioning before, and put a little suffix below, this patient is at high risk for osteoporosis. Certain fractures in the extremities, certain in the spine, certain Hounsfield units, even opportunistically obtained on an abdominal CT, will help us greatly with that. And I think by putting that in there, now that electronic medical records are openly available for patients, this may hopefully raise awareness that primary care doctors feel the urge to kind of initiate treatment. The socioeconomic downfall of this is just dramatic. So a systemic solution involving radiologists and ER doctors, I think, would help. Thank you.
Jens, that is a great point, because it's so easy to measure the Hounsfield units from the CT scans. And every person that goes into an ER gets a CT scan of something. And they should, unfortunately, it really falls on the radiologist to make those measurements.
Yeah,
it's really interesting. There was a recent query, meaning a survey of internal medicine doctors, and they were asked specifically, if this information was available to you, would you want it? And their answer was overwhelmingly no. Meaning that if you could have this information freely delivered to you, meaning that you weren't asking for it, but they gave you this information freely, but you weren't asking for it. You weren't interested in knowing that the patient had osteopenia or osteoporosis, but they just gave you this information for free off of an abdominal CT or off of a chest CT. Would you be interested, if this information wasn't clinically relevant to the question that you were asking, would you actually be interested? The greater than, it wasn't a majority, but the largest percentage of respondents of internal medicine doctors or primary care doctors actually said they did not want that information.
Well, as Jen said, it's a systemic problem, the fact that people are not even interested in it. But yet when we see these patients with osteoporosis, they're big problems.
I agree.
Yeah, certainly. I think as Brian jumps into the cases here, we'll see sort of the end effects, which is, I think, what we're sensitive to. But, obviously, preventative measures are probably the key for all of this.
All right. Well, it's a great discussion. Let's jump into some cases as well. All right. So case one is a 72-year-old female. She had a fall where she hit her chin on the edge of the counter, is what she said. So sort of a hyperextension injury. Presented to an outside ED and revealed a cervical spine fracture and was transferred to the Mayo Clinic, Rochester. As far as her past medical history, she had hypertension, hyperlipidemia, IBS, and already was diagnosed with osteoporosis with an DEXA of -2.6. On physical exam, she was 5 out of 5, strength throughout, and no neurodeficits. So I will attempt to scroll through these. So here's her sagittal CT scan. You can see she's got a fracture through the body of C2, and then with extension into, this is the right side, into the pars here, with some disruption of the C1, C2 joint, and here on axials. And then lastly on coronal sections. You can see through here, there's sort of a type 3 odontoid with extension. Right. Of course, she got an MRI just to ensure that there was no other bony stenosis or canal compromise or anything like that we could appreciate. And so you can see here the repeat of the C2 fracture and no other issues further down below. You can see no central stenosis throughout C2 through C7. Okay, so just to kind of summarize a little bit. So she's the 72-year-old female, atypical type 3 odontoid, extension into the right pars, had displacement of the right C1, C2 facet, obviously with a potential for maybe a cock robin deformity if that disruption continued in that joint. And so just to kind of briefly, just points to think about, treatment options. Would anyone go sort of the non-operative route and then just a cervical collar? And then operatively, is this a posterior C1, C2 fusion, different, obviously, screw trajectory types, transarticular screws, the independent C1, C2 fixation, kind of the Goal and Harms technique. And then other sort of just things to pose to the panel are, preservation versus sacrifice to the C2 nerve root, any techniques on C1, C2 joint decortication, reduction techniques, and then in terms of bone block, bone grafting, use of BMP, things along those lines. And I just put in here the anterior C1, C2 fusion, but obviously this person wouldn't be likely a candidate or anything along those lines, at least in the things that I've seen. So
I think, Brian, we have Dr. Chapman on, who's obviously got a lot of expertise in geriatric odontoid fractures. Jens, is this something that you would treat in a collar or something that you would think about surgery for?
Yeah, thank you for the question, and this is a great case. Just looking at the images and assuming this patient was cognitively with it and has no closed head injury, I would find that to be a very clear and humanely treated surgical indication. I would do it posteriorly. In our system, we would probably, whether we like it or not, get a CT angiogram because of the invasion of the vertebral transverse foramen. And I really like the Goel Harms technique, and we have a almost religious warfare between myself and my neurosurgical colleague, Dr. Oskuyan, because I'm a nerve root preserver. I do perform a facet joint fusion, and he is a nerve root sacrificer as a neurosurgeon. So, but I think that this is a beautiful case for segmental fixation. C2, I'd probably get my consent down to C3 also if I was unhappy with my fixation. I'd have my Zeem CT scanner available so I can shoot an intraoperative CT scan, make sure that I have perfect screws. I don't use navigation. So, but I think this is, especially with this three-dimensional deformity and a cock robin deformity, it would be cruel and unusual punishment to somehow treat that with a halo or something like that.
Jens, can I take exception? I mean, I think your plan is good if she progressed, but you have a relatively stable fracture, big, broad surfaces in a relatively asymptomatic patient. I mean, how sure are you that this is going to be a problem that would require potentially an involved multi-level cervical fusion?
So for me, the problem is the sagittal image on the midsection, the parasagittal image, I should say, shows a vertically displaced pars interarticularis with abutment into the C2 root. And again, this odontoid, this is a complex mixture of a type 3 odontoid and a Hangman's. I would label that an atypical Hangman's injury. So for me, this is something that in the olden days, you could put this into traction for a number of weeks and then try to get the patient up. Halos have become very unpopular for a variety of reasons, although I published that you can do it if you have a nice halo program. So your old mentor, Vern Nichols, would be unhappy with me. But this mid-sagittal point, to get to the main thing, tells me that this is a complex deformity with a three-dimensional displacement. And while in theory, treatable with non-surgical measures, it will simply get the patient up and around with a soft neck collar for 2 to 3 weeks.
Dr. Nasser, any thoughts? This is a case of mine, so I'll be curious to see. Would you treat this in a collar or treat
So,
this surgically?
You know, honestly, I think these are all great points. I probably would treat this specific one in a collar only because I've had success before, but I am worried about all of the things Dr. Chapman has mentioned, and I think this one has higher potential to develop into kind of a coronal deformity. And so this is probably one I bring back to clinic in a week. And if the deformity, if she starts looking like her head is tilting, if on x-ray, especially on open mouth odontoid, I start seeing settling here, I probably would have a low threshold to take her back, but I think the surgery would probably be similar. Now, this is not one where I would do my first x-ray at 6 weeks because I think they start getting really stiff at 6 weeks. So this is one where, number one, if they're local, if she's like lives in town within an hour's drive, she's very with it, follow-up is reasonable, I'm probably going to choose non-operative care because I'm going to say, hey, I know I'm going to get this lady back. If she's like from 4 hours away, dementia, other things going on, I may choose to be a little bit more aggressive because I just don't want her to show up, 3 months later with a fixed, really hard to fix deformity. That's going to be a lot harder to deal with. So I wouldn't blame anybody for fixing this one early, but at the same time, I've treated a lot of these non-operatively. I think if there was displacement on the original CT where I saw a big gap between the C2 lateral mass and I saw settling of the C1 lateral mass into that defect, or similarly, if I see like a big displacement of the C1 lateral mass and the occipital condyle into the C1 lateral mass, I think those are much more problematic, but there's close alignment of the C2 lateral mass here. And I think it's actually probably going to heal because there's such a huge surface area here. So I bet you this one's actually going to heal without too much issues.
I think that's a great discussion, Dr. Nasser, and just reminds us, there's more to it than trying to put the pieces back together on an x-ray, that you have to consider the patient's social situation and, all the other factors and the follow-up factors and the with it factors into that decision. So thanks for the comment.
Yeah.
All right. Yep. So just for completeness sake, we did get a CT angiogram and that ended up being normal. So all good points, Dr. Chapman. As you can imagine, just because of, as Dr. Sebastian kind of mentioned, and Dr. Chapman also mentioned kind of the displacement, we went to go ahead and do a C1 to C3 fusion. So this is kind of sort of the immediate post-operative images. And then thankfully she's a bit out. So we have some post-operative, even 6-month follow-up in 1 year follow-up. And I can actually show you, we have 1 year CT scan as well, which shows nicely good bony union through the C2, and then also sort of reduction and healing through on the right side as well, the C1, C2 junction. So. Right through there.
Thanks, Brian. So for these types of fusions, just looking at the other panelists, what's most people's preferred bone grafting techniques? Maybe Dr. Chapman, you could weigh in.
So how unstable was this injury? Was this just vertically or coronally unstable when you had her on the table? Did you use GW tongs or Mayfield?
I used the Gardner-Wells tongs.
Yeah, I thought
but once we stretched it out, then you could kind of gap the facet and it wasn't too hard.
Yeah. In terms of bone grafting, I really like the facet arthrodesis, and I put a small allograft wafer in on each side and then compress down sequentially on it. So in this case, I would do it on the non-collapsed side. And I preserve the nerve, but as I said, I found this to be very useful. In terms of outcomes, I just want to add to this. I think one of our publications has mentioned that the outcomes of these are actually surprisingly good. Older people, and I have to watch because I'm in my early 60s. Older people do not seem to miss their C1, C2 rotation that terribly. In everyday life, we're having a dedicated outcome study on this also right now with the ISSG. It really did not affect their general activities very much. So I congratulate you on being decisive. And again, as Dr. Nasser correctly pointed out, the decision has to be made early. If you wait for more than 3 weeks, this becomes a mess, and you may have to go to the occiput, which is a big quality of life adverse determinator, as opposed to a C1, C2 selective segmental fixation, which you did beautifully.
Great. Okay,
Great.
I can take
All
over
right.
for case 2 here. All right, so we'll stick in the cervical spine for this case. Here, slightly older, 85-year-old female. She did have 6 months of progressive hand weakness and numbness and trouble with fine motor skills, but had an acute worsening of her symptoms after a ground level fall. Notable past medical history is that she has a diagnosed crystalline arthropathy, which was called CPPD. She was treated with prednisone and non-steroidals for a long time. She did have a recent BMD, which showed her lowest T-score of -1.9, so in the osteopenic category. But looking opportunistically at her CT Hounsfield units on an abdominal CT, her L1 Hounsfield units were 73, so very low, what we'd consider to be in the osteoporotic category. She had weakness in her hands more than her upper arms and did have some hyperreflexia. Here were the images. We also got flexion extension images obtained in the emergency department without a collar. See a severely spondylotic cervical spine, perhaps spondylolisthesis of C2 on C3, but otherwise no obvious motion or kyphotic deformity on her standing films. Here's just some shots of the CT though, and most notably here you'll see this C1-2 pannus, both on the mid-sagittal cut as well as the axial cut. You'll notice here she did have a previous anterior C1 plow fracture. This was old. She had this on her previous imaging. So mostly it was this pannus we were looking at. She also received an MRI, and not only do we see stenosis at the C1 level from her pannus, but also then looking at the subaxial cervical spine, we see she is quite tight at the C5-6 and C6-7 levels as well. So to summarize, we've got more of an acute presentation of central cord syndrome in the setting of background cervical myelopathy in this 85-year-old female. She does have a C1-2 pannus, which is causing central stenosis, but then as demonstrated on the MRI, she has multi-level spondylosis with also C5-6 and C6-7 stenosis. So options that we considered in this case were continued non-operative management. You know, we can certainly get into a discussion of acute versus delayed treatment of central cord syndrome. This case is a little bit different in that it's not just, congenital cervical stenosis that we discovered in her, but also this multi-level spondylosis and this pannus that weighs in. Treatment options specifically for the pannus would be a C1-2 fusion without decompression, as it's been shown that that pannus does resolve in the rheumatoid patient when you just do a fusion, but you can also decompress it. Given her bone quality, also a discussion can be had extending the fusion to the occiput. And then if you're going to treat her multi-level subaxial spondylosis, would you consider doing that in a multi-level anterior or multi-level posterior approach? Or ultimately, is this treatment going to be some form of combination of the above? So if any of the panelists want to weigh in, your thoughts on acutely operating on central cord syndrome, how is that different in a patient like this? I'd love to hear your thoughts.
What's her functional level? I mean, is she a with it octogenarian or is she a chair sitter?
Yeah, no, she is. She came from home. She lives with her daughter in the house, but she actually drives. She gets around her kitchen. She grocery shops. So for an 85-year-old, she's quite independent, quite mobile.
So I think that's a great point that was just brought up. I mean, I think far too often we get biased by the first leading number of the age But oftentimes, as we all know, there are probably 85-year-olds who are more functional than 70-year-olds in our practice. Dr. Nasser, looking at this case, is this something that you would treat acutely, or put it in a collar and sort of see how she does?
I mean, I would probably bias to an acute treatment if she came in through the emergency room with, decline in function. I try to treat the problem that is more severe at C1-2 with a fusion. I probably would try to just treat C1-2 with a fusion, because I think that's really where the instability in the pannus is coming from. And so unless her occipital cervical joints are actually eroded, and sometimes you see that better on a CT, but most of the time it's really C1-2 and not so much occipital cervical joint. But I would carefully look at that occipital cervical joint, and as long as it looks like it's relatively preserved, I probably would decompress and take off the C1 ring and possibly C2 if it's needed, and fuse that joint, maybe even down to C3 if she's got a spondy there. But I would consider maybe just doing a laminoplasty at C5-6, and so trying to preserve the motion down low, trying not to fuse her to the occiput. So I would decompress everything, but try to do the least amount of fusion that I can. Just because I'm meeting her for the first time, I'm meeting her through the ER rather than through clinic. So I don't really know her as well. I don't know if she's got any dysphagia. I don't know if she's got any underlying radiculopathy. I don't see any horrible spondies at like C7-T1. So I think probably would be reasonable to do a laminoplasty below and probably just do a fusion at C1-2 with a decompression at that area. Again, that's probably in a minority opinion. I don't think it's wrong to fuse the whole thing and do a C1 down to T4 or T3 or T2. I think that would be a completely reasonable fusion construct as well, and decompress the whole thing as well. But I probably would treat it acutely if she came in through the ER with decline in function. So
You've got a really stiff subaxial spine. Our anterior column is almost fused as is. So why not just, the easy part is, why not just do a decompression at the subaxial part and not worry about fusing that? I think, C1 is a different story if you have any worries about instability. But I think, CT scan might show the same thing, that it's just as solid anteriorly, where you could get away with just some decompression and get out of Dodge on an 85-year-old.
yeah, I don't think the laminoplasty adds all that much time. Honestly, the reason I do the laminoplasty more so than just a decompression is because I think it protects you from getting some recurrent stenosis from the muscle bed just kind of collapsing down onto that cord. So if you get a post laminectomy MRI, often you'll see some recurrent stenosis often on these patients. If you get a post laminoplasty MRI, it's rare that you actually see recurrent stenosis. That laminar fragment will keep things open. Even if you have a fluid collection, they still have a little room for their cord. And so I think it's a little bit protective, but it's if it doesn't take too much longer in your hands, I think it's just a little extra step. So.
Okay, so what we elected to do was a C1 to 3 laminectomy, and then also the C4 to 6 laminectomy, all from a posterior approach, and then did a C1 to T2 fusion. Here were her immediate post-operative films. She's out to about 6 months now. Came back to clinic, much improvement in her myelopathy symptoms. Actually, she's got 4 out of 5 hand intrinsics, but the remainder of the strength in her upper extremities improved. And from a functional standpoint, she's stopped driving now, has noticed a decreased motion, and that's limited her ability to drive. So daughter drives, but otherwise doing well.
Dr. Sebastian, can you comment a little bit on why you ended up choosing a transarticular screw for her versus a more segmental approach like you showed in the last case? So what about her anatomy made you choose this construct versus a C1 screw?
So I think, it's a good comment. I think In this case, I think
So
we probably got a
yeah,
little high on our C1 screws. They are below the joint, but I think if I'm being critical, we probably could have aimed a little bit lower with that screw. But this was a harm screw that we were putting in. I just only after the after we looked at it a little bit more critically, I think we probably could have aimed a little bit more straight ahead. This is kind of like more caudal to cranial in our.
Sorry, I misinterpreted it. I thought it was a transarticular screw. It's just a caudal to cranial C1 screw. Sorry about that.
Yeah, you got it. I think the point about the laminoplasty is actually really well taken. Now that I look sort of retrospectively at this, I didn't really think about it at the time. But certainly the only area that she probably really needed the fusion was proximally. And maybe, laminoplasty would have saved her some motion. Maybe, I don't know if it would have changed her ability to drive or not, but, it's certainly, I think, something that maybe could have been considered.
I think this is very well done. I thought the idea of a laminoplasty is brilliant. I'm a fan of that procedure, and I honestly did not think about it here, but Ken Yanamura is a good friend, and he texted, isn't C1, C2 fused? And I'd be curious to hear your thoughts, Dr. Sebastian, but these storage diseases usually happen out of micromotion. So it can be deceiving if there's a bony buildup appearance, and it's the rotational forces, even if they're just very small, that lead to the storage disease. So the fusion is actually curative in this regard, and decompression is greatly aided by having this fusion. I would never want to go back in an old patient like this when there's no lamina in the back. We have to do it often enough, and that's a very difficult surgery. So I congratulate you on being clear and definitive there. And yeah, I would have fused it down to T2 also, because in that age group, you don't want to keep coming back with more surgeries. That C6-7 segment looks really bad. So addressing both segments at the same token is, I think, in the patient's best interest. Thank you.
Yeah, thanks, Jens. I mean, I think, one of the things I actually learned from Dr. Courier, who is a mentor of mine, is that, as you mentioned, there's really sort of four synovial joints in the atlantoaxial articulation, the two lateral masses, and then a synovial joint in front and behind the dens, that one behind articulating with the transverse atlantal ligament. So I think this is a process of motion, micro tears, synovial inflammation, and instability. And so in my mind, even though you see a big bony sort of calcified shell around that C1-2, I think it's still functionally probably unstable. And certainly in this case, for decompression purposes, I'd also, did a C1 laminectomy. So I'd be a little bit concerned in this setting, just doing a lamia alone. But certainly that's an interesting point.
All right, John. One of our friends, Sergio Silverstein from Porto Alegre, Brazil, had a couple questions. He said he'd like to see the result 2 years after surgery. And then the other one, he said, how long did the surgical procedure take?
Yeah, I don't have the exact time, but generally speaking, this kind of case, probably about 2.5 hours is my guess. A C2 to T2 is usually about a 2-hour case. So I think, the C1 screw does take me a little bit longer. And usually a call case like this, I scrub in from the beginning. So these older patients who are a little bit more frail, I think that's a really good point, that we want to be expeditious as well as careful. So this is not the case that, I leave the fellow in there for, an hour and a half to kind of get exposed and get started. I think this is one where we kind of come in early and try to get things moving quickly.
And if you had the same exact case today, would you do exactly the same thing?
Knowing me, yeah, probably.
You still wouldn't do the laminoplasty at the lower level?
I probably think about it, but then, probably do the same thing. But, that's my bias. And I think, again, I think a laminoplasty would, be a very reasonable option for this case. Maybe want to jump into the next one, Jim or Brian?
All right. Yep, we will continue on. Let's see. So case 3. So we'll move out of the cervical spine into the lumbar spine. So we have an 84-year-old female. She presented to the ED with a known L1 senile burst fracture after a previous ground level fall. In her description, she had 6 weeks prior a mechanical fall, presented to her PCP where she was found to have an L1 compression fracture. At the time, she was being treated conservatively with a TLSO by some outside providers due to a lack of neurologic dysfunction at the time of her injury. However, it's sort of in follow-up of the last 6 weeks, she had a period of where she was having worsening bladder dysfunction, having retention, loss of her ambulatory capacity due to worsening lumbar radiculopathy. In terms of her past medical history, she was actually quite healthy. Before this, she was quite independent in most of her activities, but she had hypertension, hypothyroidism, and osteoporosis at a DEX of -2.5. On physical exam, she had some weakness in bilateral iliopsoas, 4 out of 5 strength in quadriceps and gastrocs, and 4 out of 5 in right tibialis anterior and EHO. She also had a chronic left foot drop from a previous left foot surgery that she had. No clonus, downgoing Babinski, and then on rectal exam, she had weak volitional sphincter control, weak resting tone with, however, intact perianal sensation. Her PVR, which was obtained in the ED, had almost 500 cc's. So here, these were the images at her initial initial injury, and clearly showing an L1 burst fracture with some degenerative spondylosis throughout the lumbar spine. And then this was a CT scan obtained. You can see the L1 burst with some closing down of the canal with retropulsion here. And here's just an axial image showing just a reduction of the canal space. And she also got an MRI at this point. So she had a known incidental lipoma along the dorsal part of her conus. Right there, you can see it. And you can see, obviously, the stenosis through her central canal, both on the sagittal films as well as on the axial films, basically T12 to L2 on these axials, but predominantly compression through L1. And you can see here, this is the known lipoma that she's had on the dorsal part of her conus. So just kind of briefly decision-making time, just thinking about continuing non-operative treatment, need for a brace at this point. And if a brace, she was already being treated in a TLSO. And then I just put in here extension casting as maybe a point of just discussion when a person initially presents, whether an extension casting is an option in some of the panelist spine. And then operative sort of things to think about, decompression alone. She needed decompression infusion, the levels of fusion, and then how to address the sort of ventral decompression. Does she need a partial corpectomy, VCR, and then again, bone grafting options, whether people use intraoperative ultrasound to look at the ventral decompression, any use of junctional cement augmentation. She already has known osteoporosis. Do people do that? And sort of just as we mentioned at the very beginning of the talk, sort of postoperative osteoporosis treatment. So I'll kind of present that to the panelists and see if anyone has any opinions on this fine lady.
And so for me, this is going back to what we initially talked about, not but a general medical systems failure, which we see all the time. And the issue is we should have had a situation where this patient comes back very early and gets screened and gets by a vertebroplasty or kyphoplasty. So the intervention in the golden period between 1 or 3 weeks is the key measure here. And again, identifying this patient on Hounsfield units as a high-risk patient and getting her into an overbook situation where a surgeon-led indication for a vertebroplasty, kyphoplasty would have avoided this whole disaster. In our area, a private practice surgeon did a phenomenal job in getting this documented. Neil Schonert is his name. And we now actually changed the payers situation so they actually support early intervention with kyphoplasty / vertebroplasty to try to avoid just this problem. So that's my lament. Now we have a real problem to solve, and I'm curious what others have to say.
And just to clarify, Jens, so for these types of burst fractures, regardless, you guys are trying to do early kyphoplasty or vertebroplasty on them?
Yeah. So we bring them to clinic in 1 week. Now, we have a very large system here, and they're all supposed to be seen by us. And sometimes it works, and sometimes it doesn't. And we have these same disasters. I'm sure everybody has those that are so frustrating, because now we're talking about an all or nothing, very major undertaking. But in that early phase between 1 and 2 weeks, you can pretty much with a simple repeat x-ray see how the brace fits, how the patient gets around, and get a simple lateral repeat x-ray to see whether there's any early collapse. And that's the golden time to basically just cement this. By the way, if you wanted to do a decompression later on, you could do that very safely once that ventral column is supported. But this patient, just by the Hounsfield unit gestalt that I see there, looks like that's just, there's nothing in there. This is going to form an avascular necrosis of the vertebral body and just vanish. And so that's where the opportunity is to do an early intervention with a kyphoplasty or so forth, cement augmentation.
Ahmed, any thoughts on how you would manage this? Is this something that you would try to do from a lateral approach if you were to operate on it, obviously, or all posterior?
I'm so happy that it went to you. I mean, honestly, I don't think that there's an easy answer here. I think in some ways this lady's unlucky, because I think the lipoma is probably why she got into neurologic trouble here, versus maybe if she didn't have the lipoma, the corridor neurologic tissue would just have that much more room, right? And so I think she's getting squeezed from the front and squeezed from the back, and she, again, just doesn't have a lot of room here. If you wanted to really get creative and do the least amount of damage, and you wanted to really get fancy, I do think that you could probably take this out from the front. You could take the pedicle down, and you could take the vertebra out. It's soft bone, and you could probably do it by squeezing in through a lateral retractor, and you could get fancy. If you go in from the back, it's pretty easy to take out as well. So I think you got a lot of options here. I think one of the upsides of going in from the front is then maybe you could do the back percutaneously. And in somebody with sarcopenia and bad bone, maybe by saving their posterior muscle envelope, maybe there's some advantage, right? I don't know. But regardless, I think these screws are probably going to get cemented, because there's really not much bone there. Even looking at the MRI, most of her marrow is replaced by fat. And if you're putting metal in there to replace whatever you take out, I think it's going to subside. And so I think the fix is trying to fix her nerves. I think the problem is we're putting metal in there to replace it, usually is the answer. And unfortunately, the long-term fix is that she's probably going to subside and pull out her screws. And our cements right now are not the greatest, right? So, PMMA right now is has a potential of going into her lung. So we still have a lot of research to do, and I'm really hoping that we're going to have biocompatible cements in the future and better options for our patients. But right now, this is unfortunately a high-risk case for her. And like, Dr. Chapman said, this is a disaster now that we're left with, because this is some form of anterior posterior reconstruction, regardless of how you do it, in bad bone with poor potential for healing and really high chances of screw pullout and failure and need for further surgery. So, it's a tough situation that you're being put in. So.
All right. Well, great discussion, just sort of in the interest of time. So as Dr. Nasser mentioned, she got the full gamut. So she got a VCR at L1 and then 3 up, 3 down from that level to stabilize her. And these were the intraop fluoros. So T10 to L4 posterior fusion with the L1 VCR. And then this is sort of some intraoperative photos, which are nice to see. So she had some allograft rib also placed across and sort of secured with the cross links laying across the bony bed there. And then she was in the hospital for a little bit in terms of, she also got cement augmentation, as Dr. Nasser correctly guessed. So basically T9, T10, and then at L4 also got some cement augmentation done there. And you'll notice even in the, she was still in the hospital during this time. You can see that the cage actually had subsided a bit as well into L2 here. So, and then this, and then in terms of her postoperative course, so she also got Evenity or romosozumab. Sorry, I can't pronounce that. I can never pronounce it. Evenity, 1 year post-op. So her DEXA went from negative 2.0 from negative 2.5. And she ultimately regained a baseline level of independence. And so here's her 1 year post-op. So, but overall doing quite well.
On a kind of another note, does anybody have a preference as to, their anabolic of choice, in sort of the acute setting? I sort of defer to our endocrinologist, but anybody else on the panel have some more expertise that they could share with the group?
I think the data is starting to show that Romo or Evenity probably has the highest bone density gains in the short term. And so even 1 to 2 months of treatment, we actually can see substantial gains with Romo. At 6 months, it probably has the highest of all of the anabolic treatments so far. So I do think that this is probably the right choice for somebody that you need to acutely operate on. And plus it can be administered in the hospital as an inpatient, like, immediately, like they're admitted, they have a fracture. You could probably get their first dose while they're in the hospital getting treated for their fracture. So I think this is the right choice for this patient, and probably gives you your fastest bone density gains. So.
We have another question from Sergio. He says, surgery too big for the basic purpose. Any thoughts?
Yeah, I mean, I think, certainly I'm open to, the criticism, for this patient. I'm obviously concerned about fixation. And, so I did go long in this case. Perhaps, others would feel more confident doing more short segment fixation with, bicortical screws, or maybe a sort of a more minimally invasive lateral approach with some sort of lateral fixation and pedicle screws on the backside. I don't know, Dr. Chapman, you certainly have more trauma experience than I do. Would you have tried something different here?
Jens, are you still on? Maybe not.
Yeah, you probably
Maybe
want to go back
not.
to surgery.
Yeah, maybe you had to go back to surgery. But I think there's maybe several different ways to tackle this. In my hands, this sort of just felt like the most straightforward. Well, it looks like we're 7:59 here, so I think we'll wrap it up. Thanks, Brian and Jim, for leading the session and putting everything together. We really appreciate your hard work. Thank you, Dr. Nasser.